And I'll start screen sharing just to lead us in, or hopefully to warm us up to Dr. Manalo's presentation. Let's do that. Yeah. Going to be seeing my screen. And we are in the community that we established a year ago, Dr. Manalo. Just wanted to give you some kind of context about how we got here. Um, Last year, we decided to produce this community first before any product because we wanted to reach out to other members of the community, researchers, people that have been doing this far longer than we have, to see if we can have some kind of discussion around three disciplines that we found to be very important for our work. The first one was proactive family involvement. We wanted to carve out this space for that purpose. And of course, shared decision making and advanced care planning. But more than me, I would like Bill to at least tell us about himself and this community that we're building, because we're also creating a new space aside from what we've got right now. So, Bill, I'll just share the screen while you share a little bit about yourself and the work that you're doing.
Uh, Magandang umaga, magandang gabi, wherever we are right now. I'm Bill, a product of UP, Los Baños. And well, my basic background information really is from the two A's, which is arts and agriculture. But at the same time, there's always a passion for learning other things and more substantial things. And this led me to a path of discovery with advocacy regarding with personal experiences regarding with mortality itself. Uh, and just the maybe start of the curiosity itself of how people view things in terms of philosophies, beliefs, and values. Uh, when I was invited during the COVID era to be here uh, to to lend a hand from a standpoint of the research uh, research arm in scouting research papers. We started from somewhere with a different reiteration. And I would also want to acknowledge that I was also watching Dr. Manalo, your YouTube video. There was a YouTube, I think there were three or four. And you mentioned about the start where you started regarding with cancer, with cancer patients. For us personally, from my side, it started with Alzheimer's and dementia. So, and then it translated to more of the serious terminal illnesses. We are developing a web platform, a whole family matter, and it's a more so a learning and reflection space for individuals and families on their thoughts regarding three things: serious illness, end of life decisions, and personal values. Uh, but it does go beyond the courses. Right now, I'm where the screen is, uh, the ICP Dependent Care Planning ICP platform. Uh, this is already a collection of question number 2 to question 23 of the total of questions, 30 questions. I've been developing with it with the aid of AI at the same time. And it goes beyond just the courses because it serves as a community experience. We are not here personally to feed them the answers, but much so to be facilitators, to forge their own paths in finding their answers. We are here to, for me, the three things that stands out is to provide clarity, exercise compassion, and celebrate the courage that it takes them to talk about these things. So basically, that's where I'm tasked upon in my daily in and out with this platform. And hopefully it can serve as a resource, sort of a library for their expansion of knowledge.
Wow, Bill, thank you for that. That's a really good, wow, substantiation of everything that you do. Just go. Bill has been working with us for 5 years now, and it took us a while to get around to at least learning what tool we can use to build courses like this. But what you're seeing, Dr. Manalo, is a resource or a course for supporting users that are going to be using the application that Kismet is working on. And these questions that you see or these sections of content that you see are basically in support of the content that we have on the app. So I will now pass it on to Kismet so I can at least also share about the app that she has created for a whole family matter. Okay.
Hello, Dr. Manalo, and hello everyone else. And I'm Kismet Swan. I am the platform innovation lead of a whole family matter app. So this is what we've been building for almost 6 months now. And yeah, before I go into details on what this app is all about, I am a ComSci graduate, but initially I want to take up biology and hopefully become a doctor in the future, as that's what my parents always wanted me to be. And I don't know why I landed into tech, but I guess building things that actually are, substantial and that actually helps the community is something that I'm really passionate about. And I'm glad that I was able to work along with Sir Norman and Sir Bill on this A Whole Family Matter app. So this is actually a very unique project, as I've never dealt with this, or this is my first time hearing about advanced care planning. And sometimes it gets a little bit too heavy when you're working on it every day, but I always try to separate my work from my emotions. I don't let it get to the best of me. And yeah, this is what I've done in the span of 6 months now. And I could explain to you all about the individual features, but I think we have a 3-minute video that encompasses all of it. And I think we can share it with Dr. Manalo to the link because medyo laggy siya if we send it or if we play it here on Zoom and the background audio was not also audible as well. But I'm really glad that we are all here today for the launch and for Dr. Manalo's talk as well. And I'm very excited to hear about the status or the advanced care planning here in the Philippines, as talking about that is very taboo and it's something that we don't always want to speak in our family. We always say, "Ay, wag yan. Let's not talk about that. Let's not go there yet. We will cross the bridge when we get there." And when we get there, it's almost like, hindi kami prepared. Wala. It's always so heavy. We don't know what to do. We don't know how to deal with this because we haven't had the chance to talk about it as a whole family matter. And this is why we believe that it's important. What we are building right now will be very helpful to a lot of families worldwide, especially here in the Philippines, where our healthcare system is, well, I wouldn't say it's the best, of course. So yeah, I don't want to take up much time since I know na I'm very excited to hear about what Dr. Manalo has to say for today.
So yes, Dr. Manalo, as you can see, no, we have been hard at work for the last 6 months, of course, but definitely for the last 7 years now. This has been an ongoing life project for me, and I have just been very fortunate, especially, of course, to work with people like Bill, and definitely a talent like Kismet to produce something like this. Because I would like to ask you, Dr. Manalo, have you seen any advanced care application that is very specific for group work, for families working on advanced care planning together?
Usually individual. It's the
Right.
patient who makes it.
Yeah. And that's what we found, actually, that it's a very individualist um, adventure It's usually done by one person, but here, as you can see, if I can demonstrate with just a few clicks, it was really fantastic to discover that. Oh yeah, I recorded myself after some questions, but it's to answer questions directly. For every questions, there are options, and it's a complete application that we made for not only advanced care planning, but almost like a private social network for a family. It's just them. It's just the family being able to talk about end of life care. All right. So that's us, Dr. Manalo. I hope that you got at least an idea of where we're coming from and what we're trying to do. And what we really want is to be able to carry forward the conversation from this time, which is April 16, a very fortuitous time for advanced care planning because it's the National Healthcare Decisions Day for the United States. And I found that there are other ways to celebrate it throughout the year. There are many different celebratory days that people have anywhere in the globe. But I found that something to do with taxes and National Healthcare Decisions Day. Just to give everyone some context about this, April 15 is the final deadline for taxes in America. And April 16, they decided to be Advanced Care Planning Day. Because if taxes is something that you do, so does advanced care planning. So does something like this. So that's the reason behind today being National Healthcare Decisions Day, apparently. All right. I was hoping to give this introduction to Dr. Manalo and hopefully wait for 4 minutes, but I think this is it. The fun thing to discover about producing webinars, I know this now from last year. No matter how much effort you put into it, it's always a last minute decision for webinar attendees. So that's why for me, the real value of the webinar is not so much the live event, it's really the recording that we get out of this. Because if I can show you what I mean by that, um, we had previously done a webinar and we actually produced and captured the video of, say, a presentation. So this was last year, and this was Dr. Craig Sinclair talking about advanced care planning with life story work in Sydney, Australia. And we did that for one whole day. And we have a lot of content available on our community. And I'm showing you this because this is also where, Dr. Manalo, your presentation will live. I will be putting in a PDF, some transcriptions, and of course, the video of your presentation here as well. Okay, so now that I've shown you that, I can now stop sharing. Very good. And hopefully, Dr. Manalo, you can share your screen and we can begin your presentation.
Mhm.
All right,
Do I
Dr.
start,
Manalo,
Norma?
I
Or
wanted to first introduce our speaker, our presenter, Dr. Manalo. Um, she was highly recommended by a lot of technology because we were trying to explore the space first on who would be the best speaker of advanced care planning in the Philippines. And we didn't go by way of let's ask somebody, let's look at this from an industry point of view, but instead we did it the Google and artificial intelligence way. And it just turned out that through that process, we were able to find, wow, this is the best possible presenter that we could possibly get just because of the nature of what she does, but also the amount of research and the amount of work that she has put into advanced care planning in the first place. And I wanted to share a little bit about her before we begin so that we can at least appreciate that the presenter that we have is not your ordinary speaker about advanced care planning in the Philippines. She's been doing this for quite some time, and she is, in fact, one of the pioneers of the conversation around advanced care planning in the Philippines. And it is just our great pleasure. And of course, I think we have been very lucky to at least get her to talk with us and engage with us and hopefully, wow, present her work for us. So, just wanted to share the excitement that Bill and I had, that Kismet and I had about Dr. Manalo now talking about her work. So please welcome Dr. Maria Fidelis Manalo, Palliative Care from the Medical City of the Philippines. Thank you so much.
Hello. Thank you, Norman, for that kind introduction. And thank you, Bill and Kismet, for being here and opening the doors for me to talk to a wider audience about something that I'm passionate about, which is advanced care planning. And as you already introduced to me, what is different regarding advanced care planning that your group is trying to promote is that you want to make it something like family-based rather than an individual choice, which
Yes.
is what you usually see in practice and when you search for it in the internet. So let me share with you actually an actual research that our resident did at our institution, the Medical City. She interviewed 116 cancer patients from stages 1 to 4. They were admitted at the hospital and we tried to find out their ACP engagement. So in the first place, we start with the definition of what advanced care planning is all about. It actually involves discussing and preparing future decisions about the medical care of a patient if they become suddenly ill or unable to communicate their wishes. And the most important thing about it actually is to have meaningful conversations with their family and loved ones. And what we actually advise is that they document their preferences for care in writing by completing legal documents called advance directives. So the study that I was telling you about, which was done in May to July of 2024, it's still yet to be published, was able to identify at least 6 cultural barriers among Filipinos why they may hesitate about engaging in advanced care planning. The first is bahala na mindset. Then certain cultural taboos and stigma. We don't want to talk about death and dying. There's fear of death, and sometimes the family fears that the more you talk about death, the faster the patient will die. And then some family communication gaps, especially so that the Filipino family has this challenge nowadays that many of the family members are all over the world. There's only 1 or 2 family members who are with the patient, or sometimes all the children are actually in different parts of the world. So definitely that causes some family communication gaps, even physically, you might say. And then, of course, the decision-making burden and the language and tool relevance. Most likely, we will not be able to find ACP materials that have been translated to Filipino or any other dialect that patients may be comfortable accomplishing. So, and then, of course, in terms of legality, again, there's very little move towards formalizing their advanced care planning into advanced directives. We are not very legal-minded in our country. So let me talk about the specific barrier that really turned out to be one of the more important reasons why Filipinos hesitate about talking about death and dying, and specifically about advanced care planning. So We are familiar with this common um, expression of many Filipinos, bahala na ang Diyos. Bahala na si Lord. Huwag muna natin pag-usapan yan. And this fosters the culture of silence. We often avoid discussing serious illness and definitely not about end-of-life care. Well, for one, even when people talk about it, they actually knock on wood. You know, they were very superstitious that we have to knock on wood so that it doesn't happen because it might be bad luck. Or we simply want to protect our loved ones from worry and even depression. That's what they usually tell me. Baka ma-depress, lalo mapabilis ang pagkamatay. No? So the unintended consequence of that would be actually, in fairness, it's not like they really want to hide the truth from the patient. We would say that this collusion with the medical team, for example, the silence comes from a place of deep love. But bahala na, or in English, we say leaving it to fate, often leaves the heaviest burden of guesswork on the people we love most. So bottom line, if the patient fails to communicate her preferences for end-of-life care, the one who will need to decide for herself will be her family members. So what happens when there's no advanced care planning to guide the medical team? Definitely, there will be a lot of stress and uncertainty to the family and to the team as well. Because we need to force the family members at the bedside to make split-second choices without guidance. And then, of course, sometimes, if there's just one member of the family at the emergency room, for example, or at the floors when the patient is in a life and death situation, then they would call the rest of the family members, and there could be some disagreements about the right treatment. Some would be in favor of aggressive measures, some would be in favor of allowing natural death. And we are working along the timeline of just a few seconds to a few minutes to make a difference in the life or death of our patients. And then, of course, depending on how the family have decided, there could be guilt on the part of the person by the bedside or on the part of the people who are not yet beside the patient. No? So because they would always be second guessing themselves. No? If the patient, their mom, their dad, their sibling would have wanted things done that way, the way they had decided. So that's really medical decisions in a crisis. So we really need to clarify misperceptions on the part of patients and family members about what advanced care planning really is all about. It's not about giving up. No? It is a structured, thoughtful process to protect their loved ones from guessing. So in the first place, we actually educate the patient to choose their trusted surrogate decision maker or their proxy decision maker. Because otherwise, if they fail to identify a proxy decision maker, the law dictates who should be the legal surrogate decision maker. So we usually say if the patient is married, then the surrogate decision maker would be the spouse. If the patient's spouse is not competent to make the decision, then it would fall on the children, and hopefully the children will be in a consensus when they come up with a decision. If it were a single person or a pediatric patient, then the legal surrogate decision maker would be the parents. And then if the parents would not be competent to make decisions, then it will have to be the siblings. Hopefully they're adults of legal age, and they would be, again, in a consensus when they come up with a decision. So to save the team from having to figure out who really is the surrogate decision maker, it is advisable that the patient herself would choose and name a trusted decision maker, somebody who knows her very well and somebody who knows her value system. Okay, and then of course the next thing would be to reflect on her values and preferences. And this is one of the things we would be asking the patient, what makes life meaningful for you? And then lastly, and this is, you might say, the legal aspect of it, and what would really facilitate the work of the healthcare team is to make sure everything is put in writing rather than just a verbal ACP or a verbal advance directives, because sadly, when it's something verbal, chances are it will not be considered in practice and might totally be disregarded. So writing down the medical wishes so that the patient's voice is heard even if they can no longer speak for themselves. So there are two ways to face a crisis, an impending medical crisis, to continue with this attitude of bahala na, or on the other hand, really giving the family the gift of clarity by engaging in advanced care planning. So again, when we adopt the bahala na attitude, the family will be left guessing. There will be high stress, guilt, and panic. And then, of course, we won't be able to hear what the patient has got to say. So definitely the family will be the one dictating, and the doctors will be forced to obey the family member's decision, even if we personally may not agree with the family's decision. And chances are there will be high risk of conflict and resentments among the family members. Whereas if only the patient and the family engage in advanced care planning, then definitely choices are made ahead of time. And there's focus now on comfort, presence, and love. Patient's autonomy is honored, upheld, and the care aligns exactly with the patient's values, preferences, and wishes. And of course, it would ensure that the family will be united and at peace with the plan that the patient herself made. So the steps of ACP would be to, well, of course, this is where the guidance from the medical team really help, because of course the patient and the family members are not aware exactly how to choose. And that way, we really need to, in the first place, the way we do it in our institution would be for the medical team to convene into a multidisciplinary team meeting. And among ourselves, we talk about the patient's current status and what is the real prognosis of the patient. No, and in palliative care, we actually have what is called the surprise question. Will it surprise you if this patient dies in a year's time? And I always teach the residents and the fellows that if the answer to that question is no, I won't be surprised if the patient dies in a year's time. At the very least, you should have been doing the advanced care planning a year before the actual medical crisis that we expect or you might say anticipate happening. So that's somehow how we know that it's definitely time to do some advanced care planning. Will it surprise you if your patient dies within a year's time? Okay, if no, then make sure you do the advanced care planning already when the patient is still relatively well and is capable of making decisions. So here, we need to share our knowledge with the patient and the family, speaking in layman's terms, avoiding medical jargon so that they really understand what we're talking about. So here, we offer to them the different options for care. And then we tell them what is the benefits and risks of every intervention that we may be proposing to them, and how that will impact not only on their life, you might say the life expectancy, but also on their quality of life. That's very, very important. So, and then of course here, we actually encourage them to already try to figure out who would be the best surrogate decision maker for them. And then we invite them to reflect internally on their values and what really matters to them, so that they feel empowered and capable of communicating their choices, not only to their proxy decision maker, but to the rest of the family, because chances are they may anticipate some disagreement among the rest of the family members when they actually communicate their preferences for care. And then finally, for the patient to take the final action and sign the advance directives, the formal advance directives, and preferably it is legally documented in the presence of a lawyer even. Now, let me tell you what we found out in that local study that we did in our own institution, and I would like to give the credit to our resident, Joy Kulang, and I thank her for sharing the results of their research paper with me. So it's a recent study, as I said, way back only in 2024. And this study among our cancer patients in our hospital 116 of them, revealed powerful truths. So, for example, patients understand advanced care planning, but they get stuck in the actual implementation. Their readiness to actually talk to family members dropped significantly. So, they used a 5-point Likert scale. So, the higher the score, the better it is. So, here, in terms of knowledge, patients know what to do, but their score is only 3.86 out of 5. In terms of overall engagement, meaning do they really want to go into the process of advanced care planning, their score is only 3.17 over 5. And then the readiness, as I said, drops to 2.96 over 5. They hesitate to act. So they know about it, they are engaged in wanting to do advanced care planning, but in reality, chances are they will not get down to doing it. So what happens? Where is the communication gap? And as is typical of many Filipinos, they have a lot of trust and confidence with doctors. We always say they treat us as if we were God. They really listen to everything we tell them and are very, very obedient many times to what we tell them. So we doctors have to have the responsibility to practice ethics in our dealings with our patients, specifically truthfulness. That I personally aim for full disclosure. It may be a gradual disclosure, but definitely I always make sure that every dying patient knows she is dying. It would be quite unusual for me to withhold the reality of death to any patient because I believe that we only die once and we better do it as best as we could. Okay, so as far as our patients at the Medical City was concerned, they are very confident discussing their medical choices, 3.96 over 5 with their doctors. Okay, they're very, very honest with their choices. But when it comes to discussing their preferences for care with their family members, it dropped to 2.95 over 5. Okay, so, and our data tells a striking story. Filipino patients feel highly confident talking to their doctors, but when it comes to discussing end-of-life wishes with their own family, their confidence and readiness plummet. So, why is it so hard for patients to discuss advanced care planning, their preferences for care with their family members? So their usual reason would be, I don't want to cause them emotional pain or to make them cry. And then on the part of family members, we must stay purely optimistic. Talking about advanced care planning means we are giving up. Okay, so our data shows that the readiness to discuss health threats with family is only 2.52 over 5 because it continues to be taboo. It is the elephant in the room. And as I said, the reluctance comes entirely from love. You might say a misplaced love maybe, but it's still out of love and concern for one another. No one speaks about their true fears because everyone is trying to protect each other, resulting in that collusion and a dangerous silence. And sadly, what we don't like as medical practitioners is that they tell us to keep silent as well, which, to be honest, I refuse to do. That means I have to counsel the family members so that eventually they will see the light and they will allow me to talk to the patient very clearly about their preferences for care. Okay, so as I said, part of advanced care planning is to make sure they identify their trusted surrogate decision maker. So actually, luckily enough, our data show that there is a readiness on the part of patients to designate a proxy, 3.59 over 5. And just to define what is a medical proxy or a surrogate decision maker is all about, it's the one who will speak on behalf of the patient if the patient can no longer verbalize their preferences for care. But we actually tell the proxy decision maker that you're not supposed to make your own choices. Okay? Your job is to be the voice of the patient when they can no longer speak. Okay? And it's very important to name only one surrogate decision maker, because if you make everybody becomes surrogate decision makers, then that's when all the conflicts happen, and it takes them forever to make a decision. So, and then they will keep the medical team waiting, and in the meantime, the patient suffers the consequences of their choice. Okay, so we have to be kind of flexible about how the patient and the surrogate decision maker will have to make choices on behalf of the patient. So that's why we have to tell the patient what kind of surrogacy do you want from this person. Do you want them to follow your written wishes exactly, no matter what? So that means what I instructed, I have instructed. Like Pontius Pilate, no, what I have written, I have written. That's it. There's no bending my wishes. You follow my wishes to the letter. Or on the other hand, the patient might give a lot of leeway to the surrogate decision maker, trusting in the proxy's judgment if the medical situation changes, because medical situations change by the day. So, as I said, from our data, there's the readiness to discuss flexibility with the proxy, but it's only at 2.79 over 5. So we advise the patient that once they have chosen their surrogate decision maker, they need to be clear how much leeway they are giving the surrogate decision maker. Giving them explicit permission to be flexible as medical realities change relieves immense guilt and pressure from the surrogate decision maker. Because that means they will have to really listen very well to what the doctors are saying and to weigh the options very, very well, always considering the patient's expressed wishes and values. So ACP, as you are promoting, should be something between the patient, the family, and the doctors. And this is very much in keeping with the collective mindset that we have as Filipinos. Sama-sama tayo, buong pamilya tayo. So the patient, the family, and the doctors, sama-sama tayong magpaplano. So we want to be clear that ACP is not a medical hurdle. It is a family communication hurdle, because talking to their family is the hardest part for the patients. As I said, the score is only 2.52 over 5, but asking the doctor's question is the easiest for them, 3.69 over 5. So the solution is clear. Ask their doctor to facilitate a family meeting, and they will discuss their advance directives. So somehow the doctor will become the mediator, and the discussion will be in a safe place, a safe space, and everybody could freely speak up on what is in their mind and in their heart. So what could be in the agenda for that advanced care planning discussions? So as I said, they need to appoint the proxy. Then they would want to look at their quality of life as well. What specific health situations make life not worth living for you? And then, of course, discuss palliative care. Again, maybe you are not aware of it. I actually am not very popular among family members. The moment they mention palliative care, and definitely the moment they mention hospice care, they will say, no, we don't want palliative care. No, we don't want hospice care. We're not giving up. We're not yet there. So we will continue treating, and only if everything else fails, then maybe we will consider palliative care. So ever since I personally started palliative care at the Medical City in 2007, we have made some headway, because we have also incorporated it in the medical school. So the Ateneo School of Medicine and Public Health has it in their curriculum that our clerks and interns are very exposed to palliative care when they rotate with us in the hospital. So the doctor has to gently introduce the concept of palliative care to patients and families. So, and then once they allow us to be part of the team, then that's the only time we can actually talk to them and ask them their exact preferences for care at the end of life. And then, of course, hopefully, they get down to actually drafting their advanced directives. Okay, and here it says readiness to sign papers is currently at a critical low, 2.65/5. But we insist that this must be completed to protect the surrogate decision maker, because sometimes the surrogate decision maker feels all alone trying to defend the patient's expressed wishes, and the rest of the family can gang up on that person and try to convince the person that that's not the way mommy or daddy wanted care, and you'd better believe us, we know our parent more than you do, things like that. Okay, so that's why everything has to be black and white in a signed document, and preferably authorized by a lawyer. Okay, so and how does the patient start talking about matters that are important to them? So, as I said, they have to do it in a very roundabout way. So maybe this could be some of their conversation pieces that to begin the discussion. Like, I was reading an article about how families make medical decisions in an emergency, and it made me think. Or, I love you all so much, and I want to make sure I never put you in a tough spot if I get very sick. And can we talk over dinner about what matters most to me regarding my healthcare? This is ideal, but I don't think it really happens in real life in most Filipino families. So we need to break the ice with love, not fear. Well, that's our advice. And well, more and more as time goes by, many patients now are beginning to talk about advanced care planning. From my experience, the one who engage in advanced care planning are more or less in the middle age group, well, in their 50s, in their 60s. But the ones who are younger and the ones who are older hardly engage in advanced care planning. So what does the Catholic Church say about advanced care planning? Is it all right to do advanced care planning? And do they support it? Or is it against the church to even think of doing advanced care planning? And the answer to this is a resounding yes. Again, I wrote a chapter in a book on advanced care planning in the Asia Pacific, and the book, the section of that book is all about advanced care planning and Catholicism. That's the section that was that I wrote about, and so I need to really look into the references on Catholic materials. What is it that makes for a Catholic advanced directive? And there are 5 major things that patients and families need to consider. Well, bottom line, what we want is dignity at the end of life, no? And that means we need to consider that there should be adequate pain relief, that we look into the proportionality of treatments, we look into nutrition and hydration. Definitely the Catholic Church is against euthanasia, physician-assisted suicide, and all other forms of mercy killing. And definitely for Catholics, we look forward to and they actually ask for spiritual care at the end of life. So many of these can actually be read from the Catechism of the Catholic Church, the official document of the Catholic Church. So on the first point, though, that pain relief is a basic human right, and doctors are duty-bound to make sure that there's adequate analgesia for patients. Nobody should be made to suffer unnecessarily because of lack of knowledge or some misperceptions on the part of the healthcare team. So we definitely recommend adequate analgesia using narcotics, opioid analgesics even. So, and the intended goal is to alleviate suffering. And of course, since they are narcotics, there will always be that possibility of causing respiratory depression, meaning the respiratory rate of the patient may go down because that's how the narcotics, specifically morphine, work. But on the other hand, we are very much in line with the ethical principle of the double effect, that our action of administering narcotic analgesics is supposed to relieve severe pain, but this possibility of perhaps decreasing the respiratory rate is allowed by the Catholic Church, allowed by God, you might say, because what you want is relief from symptom, and definitely you are not going to hasten the death of your patients. So that's what basically the principle of double effect is all about, no? And the church recommends palliative care. It's recognized by the church as a special form of disinterested charity and is encouraged. The Pope actually convenes palliative care specialists in Rome, and they will have a special session with the Pope, not really discussing about respecting dignity at the end of life. So many popes have been behind the promotion of palliative care. And then the second principle, that we look into the proportionality of life-sustaining treatment. So the ordinary means or the proportionate means of life support is morally obligatory, because these are treatments that offer a reasonable hope of benefit and do not impose excessive burden or expense. And usually we talk about nutrition by mouth, making the patient drink by mouth, and then of course the loving care of the patient, the family, and then the healthcare team would provide the patients. But on the other hand, of course, in the hospital setting, especially in a tertiary hospital, there are a lot of life-sustaining treatments that we can offer patients. At the beginning, they may be ordinary because the benefits outweigh the burden, but later on in the course of a patient's illness, the previously ordinary means now become extraordinary or disproportionate means of life support, because now the risk and the burdens have become more weighty compared to the benefits. We have seen through time that what we have initially initiated, hoping to save the life of the patient, is actually no longer working and is actually causing more suffering to the patient. So that's why we call them extraordinary or disproportionate means of life support. And morally, they are not obligatory. In other words, they have now become optional. The healthcare team is not obliged to pursue treatments considered burdensome, dangerous, or disproportionate to the expected outcome. The patient is not getting any better. In fact, we're making the patient suffer more. So the key concept here would be refusing disproportionate treatment is not a willingness to cause death. It is simply accepting the inability to impede death. And this is from the Catechism of the Catholic Church. Then, in the Filipino culture, eating, feeding is loving. Okay, so even if the patient cannot swallow or doesn't want to eat, awayan, you have to eat. You have to eat. If you don't eat, you're going to die. Okay, so this is always a point of conflict between patients and family members. Magsusumbong ang family sa akin, magsusumbong ang patient sa akin. So pareho sila magsusumbong na nagpipilitan sila, dapat kumain ang pasyente. So what does the Catholic Church teach about artificial nutrition and hydration? So the baseline rule would be failing to provide nutrition and hydration to intentionally end life constitutes euthanasia and is always wrong. So we will never deliberately withhold food and water in a patient who needs it and in a patient who can tolerate it. Okay, so they need it and they can actually tolerate it. There's no medical contraindication to feeding the patient. On the other hand, if administering food and water, especially if it's done artificially, is no longer beneficial to the patient because the body now cannot absorb or metabolize the food and water, then there is the option not to force feed or to artificially hydrate the patient. Okay, and this usually applies to our palliative care patients at the end of life. So suspending IV nutrition when the body fails does not unlawfully hasten death. It respects the natural course of the terminal illness. And in fact, we caution family members that overfeeding and overhydrating can actually kill the patient, because the patient is not able to absorb and digest the food. So what happens? The food and water remains in their stomach. The stomach bloats. The patient feels the discomfort of the bloatedness. And then since there's only a certain capacity to the expansion of the stomach, then there is the danger that it will regurgitate, go up to the esophagus, and then reach the lungs, cause aspiration and aspiration pneumonia. So you have a dying patient who might become breathless only because the family forced fed the patient or overhydrated the patient. On the part of the healthcare team, if we overhydrate patients, we make things worse. We worsen the edema, we worsen their secretions. So again, they suffer more discomfort, they become more breathless. And that's not what we want. We don't want to be the cause of the breathlessness of the patient only because we overhydrated them. Okay, and as I said, if there's one thing the Catholic Church is very, very clear about, no, it's this respect for life and the respect for the dignity of every human being. So definitely killing is against the fifth commandment, and the church will always protect the life and dignity of every individual, regardless of their medical condition and capacities. So the church is against euthanasia, which by definition is an action or omission of itself or by intention causes the death to eliminate the suffering. So bottom line, this is mercy killing. And you might be say, what it does is to eliminate the sufferer to eliminate the suffering, which is very, very wrong. You don't eliminate the sufferer to eliminate the suffering. So direct euthanasia is morally unacceptable and contrary to the human person's dignity and the respect due to their creator. But while aggressive palliative sedation is acceptable to relieve intractable suffering, interventions designed specifically to terminate life are strictly prohibited. Again, that's from the Catechism of the Catholic Church. So I want to clarify that the church allows for palliative sedation, meaning if the patient is suffering so much from severe pain, from severe breathlessness, massive bleeding, intense anxiety because of everything that they're experiencing, then we have to give something to calm them down. And the way to calm down the patient would be to give some sedatives. But I always mention the word, we are giving sedatives, not anesthetics. Sedative, pampatulog. Pag natutulog, pwedeng gumising. Anesthesia, pampatulog, pero hindi magigising kasi nga pwede ka mag-opera. Kasi nga, yun ang understanding usually natin pag sinabi mo bibigyan ka ng anesthesia. Patutulugin ka para makapag-opera ang mga doktor. So in palliative sedation, we use sedatives, not anesthetics. Okay. So, this is actually my final slide. Advanced care planning is not about preparing for death. I always say I am a palliative care physician. I am not Dr. Death. I'm not the doctor of the dying. I'm actually the doctor of the living. Because what we do is about improving the quality of life of living patients, no? And what we want is actually to uphold the dignity of every patient who were referred to us. And advanced care planning is part of what we do on a day-to-day basis. And it's about protecting the living, no? By transforming the bahala na attitude of most Filipinos into clear communication, we give our families the ultimate gift, the freedom to focus on love, not logistics, when it matters most. So that's the end of my presentation. And as I said, I would like to acknowledge that many of the data I have shared with you today came from a study that was done in our own institution by Dr. Joy Kulang and the rest of the team. Thank you very much for listening.
Thank you so much, Dr. Manalo. That was really something. It was really fun for me to follow the slides, and also to take some notes as I went along because a lot of this has been diligently and thoroughly researched by Bill and me when it comes to very substantial details around number one. And this is going to be my number one question, I think, because I was so happy that you talked about it. It's the culture of silence. When we discovered that, I myself was so shocked that how can this be possible that the family does not even want to tell a patient that they're dying? How can advanced care planning even happen if that's the case? That, okay, as a family member, I love my family member so much, therefore I'm not going to tell that person that that person is dying. And so And I think also, Dr. Manalo, that this is not just what you recorded. I think this is a culture. I think this is happening. This is not just, okay, maybe someone recorded this to have happened once or twice. I think that the data that I saw and the qualification of the presentation that you gave us today, I really think it's that way. I was just so surprised that it is actually true and how true it is. There's even a number like 73% or something, or a specific number that when I found it out, I couldn't. Wow, I have to ask Dr. Manalo if this is really true because I was even like shy to ask it. Maybe it's not true. Maybe I read something wrong. But from the way that you're nodding, Dr. Manalo, you're basically saying it's the truth. It's something that happens in our country. Okay. Wow.
And in the era of evidence-based medicine,
Mhm.
precisely the paper of the residents and the fellows confirms what we observe on a day-to-day basis in our clinical practice. Now, so as I said, the ones who are very open about disclosing the prognosis to the patient would be this middle-age group
Right.
who have more exposure to the Western way of doing things. Many of them have been abroad, they
Right.
have studied abroad or worked abroad, and so they're exposed to this whole way of thinking and acting.
Mhm.
But in the Filipino culture, it's still not something that anybody would openly talk about.
Mm.
So that's what we have to contend with day in and day out whenever we want to do advanced care planning to our patients.
Mhm. Which is rather very surprising to think that we are also a collectivist culture. That same kind of collectivism can be either harmful or beneficial. It just depends on how you use it, I think. And we are, of course, the kind of team that's thinking, collectivism is really good, yes, but now there's evidence that collectivism can be treated in a certain way and result to a terrible outcome. So I will now open the floor. Bill, I
But let
know
me
that.
clarify first,
Yes,
Norman.
yes, yes, yes.
But precisely, in a sense,
Mhm.
this is where we, the palliative care specialists, have a big role to play.
Yes, yes.
Because since we know how to do counseling, individual
Right,
counseling and family counseling,
right.
once we sit down with the family member, especially the one who's most against disclosure of the
Mm,
patient's condition and even the fact that the patient is dying, once we manage to sit down with them, they actually change their mind. It is quite rare for me to encounter a family member who continues to stop us from
okay,
disclosure.
okay.
And besides,
Right.
whenever I talk to them, I would say, I hear you,
Mhm.
I know where you're coming from, but let
Right.
me get this straight.
Mm,
Our loyalty will always be with the patient because the relationship is between the doctor and the patient.
right.
If the patient specifically asks me about their prognosis, I cannot deceive them, I cannot lie.
Mhm.
You could be there in the room. If the patient asks me how they are, I will tell them the truth. But maybe it's good for you to know that we don't disclose the truth in a brutal manner.
Of course.
We actually follow a protocol for disclosing bad news. We call it the Spikes Protocol.
Right.
All doctors, well, at least the modern day doctors,
Yeah.
we teach in the medical school how to break bad news.
Right.
We have practice sessions with medical students,
Right.
clerks and interns, residents about how to disclose bad news. So
Right.
the modern day doctors are quite competent and confident in disclosing bad news in a very empathetic way. So we don't just, drop the bomb and wait for the damage to be done. No.
Right.
So I would even run them through how we do the breaking of the bad news.
Oh,
And
good.
then once they're assured that, wow, so that's how you break bad news, it's not so bad after all. And they allow us to break the bad news, and they're actually very, very happy the moment we have done so, because now they have the freedom precisely to talk to the patient about what to do next.
Oh.
So it's just an initial reaction.
Mm-hmm.
But the caveat there is if you refer to palliative care. If you don't refer to palliative care, nobody will initiate
Mm.
breaking the bad news to the patient despite family disapproval or family antagonism.
Right.
The attending physician will usually respect what the family would tell them to do, but
Okay.
we don't stop, you know. We're that kind of people. We will always insist that the truth need to be known by the patient. So we get down to overcoming the hurdle by sitting down and doing counseling to the family members.
Okay. Well, thank you so much for that because, like I said, the number one surprise for me was that. And then in your presentation, the number two thing for me was seeing the same picture, the same thing, the one that you showed us about family at the table with the doctor in a circle. It's the same presentation from last year by Dr. Megan Matos. It's the same idea. And I actually asked her, how often does that really happen? Where you have the doctor and the family sitting at the table talking about this. And for her too, it was, that's an ideal situation. But I still wanted to know, Dr. Manalo, in the Filipino context, does that actually really happen that you have them all together seated at the table talking to each other this way?
I actually would like to, highlight the fact
Mm-hmm.
that the whole idea of a multidisciplinary team meeting and family meeting
Mm-hmm.
is norm,
Mm-hmm.
standard of care in our institution.
Great.
Upon diagnosis of a serious illness,
Mm-hmm.
especially if there's a downward trend
Mm-hmm.
in the clinical condition of the patient, automatically the doctors will call for a multidisciplinary team meeting, not just once but several times in the course of the illness of the patient,
Mm-hmm.
and sit down not only with the doctors and the nurses but also with the patient if they are able to attend,
Mm-hmm.
with the family. And sometimes, as I said, we are now living at a time when many family members are abroad.
Right.
Actually, we do it via Zoom event. Late into the night, we are doing multidisciplinary team meeting and family meeting with the patient and the family,
Mm-hmm.
because we need to make sure that everybody's on the same page and everybody hears the patient's
Mm-hmm.
preferences for care.
Mm-hmm.
So that's why we're very proud of how we do things at the medical
I know.
city.
Yeah.
And in fact, it's actually an internationally accredited hospital. We call it
Right.
JCIA accreditation. And
Yeah.
in that sense, we follow international norms when it comes to care.
Right.
So definitely, when you say, we call it MDTC, let's have a family meeting. Okay,
Right.
fine. The nurse will start
Right.
getting everyone together and then
Right.
coming up with a common time with the doctors and the
Right.
patients and the families. And then
Right.
they will reserve already the conference room
Right.
and then the meeting will take place. But sadly,
Mm-hmm.
that happens in some institutions where there are palliative care specialists practicing,
Mm-hmm.
but in places where there's no idea of a palliative care to begin with, and there's no
Mm-hmm.
palliative care specialist,
Mm-hmm.
it's not something you see.
It's not something you see. Okay.
It's rare.
Right.
It's totally like, what? FTTC?
Okay.
What's that?
Right.
I have no idea of what an FTTC is all about.
Right.
So that's why we're very proud.
Right.
And for this, I would like to acknowledge that actually the former director of the Cancer Center, Dr. Manuel Francisco Rojas,
Right.
who's a colorectal surgeon, who
Okay.
pioneered it in our institution.
Oh, good.
No,
Right. Right.
he pioneered it at the Cancer Center where we work. So
Right.
all of us learned it earlier on in our practice, and then
Right.
now it's a culture of MDTCs at the medical city. And in some hospitals, they do have it as well at the Kidney Institute, but at UPPGH,
Right.
but in other hospitals, no, sadly.
Because what you just shared made me think, all right, okay, as long as a palliative care specialist is there, that is bound to happen. Begs the question, how often is the palliative care specialist in that conversation across the country? How many palliative care specialists do we have in the Philippines, Dr. Manalo?
Definitely less than 100.
All right. Okay.
So
Wow.
we're, I think if I'm not mistaken, we're about 80, 81 now.
81. Okay.
And sadly, some of our graduates even do not get to practice palliative care. And you might ask, why?
Okay.
After having done subspecialization in palliative care, you're not practicing?
Right.
Because doctors are not and families are not open to palliative care.
Okay.
They're not. So
Okay.
you have a palliative care specialist in a clinic, in a hospital, and
Right.
nobody refers to them.
Wow.
So
They're there. They're actually there at the hospital. A family's there in the same hospital, but they're not being referred to the palliative care specialist. Wow.
yes, so
Okay.
our younger graduates are actually getting discouraged. No, they're
Right.
not like us. We
Right.
are kind of,
Right. Yeah.
go, go, go kind of
Right.
people. I started a palliative care program at the Medical City, not knowing any doctor in the hospital, and there's no service, there's no policy about end of life care.
Right.
So we have to start from scratch, training doctors, training nurses, training medical students, and at this time, 15 years into the practice, it's a culture already.
Yeah.
It's very much into the culture of the hospital.
Okay. Well, thank you at least for me because those were my top three questions. I am so sure because Bill is my fellow researcher here. He's been researching this a lot with me. Bill, I'll open the mic for you to, because I'm sure that you yourself have your own questions, Bill. So please do. Your mic is not on. Oh, you have so many. Your microphone is not on. So please turn your microphone.
Yes,
Thank you.
I have like maybe seven.
Seven.
Sorry that I was jotting down while I was. This is part of my ADHD that I have to make my hand available to do something. Otherwise, I drift. But I'm actually listening, so
Okay.
that's my modality.
Okay.
Uh, where to start? Actually, okay, I'm just going to start from the first slides down.
Right.
One, Dr. Manalo, I'm just more intrigued from a research standpoint regarding with the research that was made in the local study. Uh, is there any particular with the demographics regarding like region of the not specimens, but the people that were conducted in the interview regarding with their education, with their gender? Is this most likely happening to a female patient, male patient? Locality, is this urban? Are these urban people? Well, considering that you mentioned regarding with uh, people abroad, so I would consider. But if you want to add to that, is it urban or rural? Uh, their degree of education. Are these more
Mhm.
educated people or not? Uh, you mentioned about the age that these are more on the 50s and 60s. Uh, I think from my standpoint as a researcher, that's very novel for me to have the opportunity to know it and learn it from the contextual of the Pinoy experience. Because what I've been doing for the past years was really more on the research and gathered studies coming from the West. So
Yes.
this would be a good opportunity for us to have that kind of a revelation of some sort. So that's my first question.
Okay. So it is a one-center study only done at the Medical City. The Medical City is a private academic hospital. We have our own cancer center, so it's quite known for that service. We have the palliative care unit and palliative care patients. No, the study was actually done among our patients who are age 18 and above with stages 1 to 4 cancer. The profile of most of our patients is that they come from the middle class to the upper class. We may have patients belonging to the low socioeconomic status. We have a service called Divine Mercy patients. And these patients coming from the low socioeconomic status get some financial support from the hospital, from the foundation, so that they get some discounts in terms of the hospital bill. And they are not charged the professional fees of doctors. But usually we have very few of them compared to the rest of because it's a 300 bed capacity hospital, and Divine Mercy patients are definitely a minority because many low socioeconomic patients fear going to Medical City because they know they will not be able to afford our services. They're just going to have, debts, huge debts the moment they enter the Medical City. So by choice, they will not go to the Medical City unless they're in a dire emergency, life and death, and then they have no choice but to rush to the nearest hospital. But otherwise, the ones who deliberately choose our hospitals are those coming from the middle class and, in fact, more upper class people. So that means they're very highly educated. No, they are usually mostly white collar workers rather than blue collar workers. So and most families have family members abroad because they are working there or they're studying there. So that's the profile of our patients. That's why you might say, considering that these are highly educated and kind of financially secure patients, their answers are still revealing, right? That despite their exposure to the modern world, to the Western society, there is still that hesitancy to engage in advanced care planning. So can you imagine how it would be if we conduct the study at the UPPGH where we trained in fellowship training? Most likely, they have no concept of advanced care planning whatsoever, especially as ECP forms are not in Tagalog.
Yeah.
But since I trained there precisely, since I did my fellowship training there, it's really part and parcel of our specialization to engage in advanced care planning. So Tagalog naman kaming makipag-usap sa mga pasyente na about it. Pero hindi in a formal manner.
But
So
I do
that's the profile
think
of the
that,
patient.
okay, thank you, doctor. But I think that is also the versatility that we have as Pinoys, that we from our standpoint of being more, sabihin mo, educated, we can always translate. And that kind of affinity to speak a vernacular language does translate to their confidence and agency to actually confide. So I think that's also a very good skill that we do have, because that also led me to my number 5 question regarding when you mentioned about that they don't want regarding with the hospice and palliative care. You did explain, but my initial reaction was, I was intrigued. I was more intrigued of the shutdown of thinking, where is the resistance coming from? And then when you're already talking regarding, you can affirm this or negate it regarding that it seems to be more economic in the factor, or are there other factors, no, that kind of initiates the shutdown for them to resist or be regarding with the palliative, or they just really don't have the knowledge?
I did my fellowship training at the UPPGH, Philippine General Hospital, and I think both of you are familiar with the profile of patients we have there. You have there people coming from the whole Philippines, in fact, from region 1 to 12 and beyond. Of course, still, majority of the patients will be coming from the Metro Manila area, but we do have patients from the provinces flocking to the UPPGH, and of course, most of them are really indigent patients. They come to the hospital barefooted sometimes even. So that's the stark contrast between the Medical City and UPPGH is really amazing. No? But so when we were fellows in training, in our lapel, it clearly states our name and our field, right? So when we were in training, what we put in our lapel is hospice care. Nowadays, nobody puts hospice care. Nobody puts hospice care. You put palliative care. It's the politically correct, safer terminology. The moment I go to the bedside of a patient and they read my name and my specialization, they will start crying already. And you're talking about the poor and the uneducated. Doktora, mamamatay na ba yung anak ko kaya mo pinupuntahan? Alam nila. Sabi ko, nanay naman, ikaw naman. Kaya ako'y nandito para tutulungan kita para maginhawahan yung anak mo. Hindi dahil mamamatay na necessarily yung anak mo. So, iiyak na kagad yan sa pediatric ward. The moment mabasa nila yung hospice care. Kaya nga hindi na namin nilalagay ang hospice care kasi natatakot sila. Kahit mahihirap, alam nilang ibig sabihin ng hospice care. Hindi nila alam ang palliative care pero alam nila ang hospice care. Okay, so there. So it's not the economics. It's the general misconception that palliative care, hospice care is all about end of life, and they don't want to talk about end of life.
Yeah. Mm-hmm.
That's the real reason. It's whether they can pay for it or not, it doesn't matter.
Okay. Maybe I'll just limit it to my third. Regarding with the slide on going from the Catholic Church supports, regarding with the euthanasia. So I don't know if this would be the right platform to ask you personally regarding with going with the Western or like with Canada, regarding with MAID, medical assisted aid in dying, and BSED, and regarding like other like artificial feeding, intubation, DNR, CPR. Where does the Pinoy journey or the context regarding through your experience and through your observations regarding those things?
Yes, the what we encounter in the Filipino setting is not the request for euthanasia, physician-assisted suicide, or medical aid in dying, or even the voluntary stopping of eating and drinking. Remember, I was telling you, they are not supposed to feed, they're not supposed to drink, but they will force the patient to eat and drink. Okay, so the reality in the Philippines is exactly the opposite. The patient is dying, the patient is suffering so much, they will not allow us to allow the patient to die. Even if it will cost them a lot of money, magkabaon-baon sa utang, hindi sila titigil. Hindi sila titigil. That's why nga this whole idea of us talking to them about not escalating care, limitation of treatment, because it's futile, because it's causing more suffering, mas mahabang usapan yan kaysa euthanasia. Not even in their wildest dreams will they think of euthanasia, medical assistance in dying, voluntary stopping of eating and drinking, physician-assisted suicide. I have encountered them in my personal practice. I have. And even in PGH, I have encountered requests for hastened death. That the reason for that would always be more financial than medical or even some psychological problems on the part of the patient or the family. No. Most of the time, the reason why they want to hasten the dying process is wala na silang pambayad, baon na sila sa utang. Then they don't even realize na actually, if that were the case, we are not hastening the dying. We are simply stopping burdensome treatments that are already disproportionate to the expected outcome. And it's even ethical. It's not illegal even. So that's where the clarification will have to be made. So as I said, it's a rare thing that patients and families in the Philippines would request for a hastened death. There are some exceptions, but they're rare.
Right. Well, thank you so much, Bill. And finally, Kismet. Kismet is our lead innovator and leader for the platform. And I'm sure that she has so many questions. And she also comes from this kind of background as well. Before we even got to meet Kismet, I must tell you, her background in healthcare was already there, and she was still in college during that time. So she had already been working on tools like this. So, Kismet, I'm opening the floor to you to ask your questions. Please go ahead.
Actually, most of my questions were answered along the way by Dr.
Right.
Manalo. So I just wanted to ask them if the PhilHealth covers it covers anything from palliative care, like my subsidy ba in terms of that one.
Very good question, because I was just in a meeting 2 nights ago about talking about this.
Right.
Thankfully, it's in the pipeline. We're hoping that in a matter of a few months, we have 4 packages that are now being studied by PhilHealth. We have the PhilHealth palliative care package for inpatients, palliative care patients for home care, package for home care, and then we have the hospice package for inpatients and the hospice package for home care. I suppose you know the difference between palliative care and hospice care. Now, hospice care would be more for those with a prognosis of 6 months or less, but palliative care spans quite a long period of time, in fact, no? So as long as they're suffering from a serious illness with health-related suffering. So there, we're looking forward to the PhilHealth finally approving the proposal of the society, the Philippine Society of Hospice and Palliative Medicine, so that the ordinary Filipino will benefit not only when they're admitted in the hospital, but when we are taking care of them at home.
And that's really good to hear because it's very common na kasabihan dito na even the middle class families is just one medical emergency away from going in debt or like becoming poor. So, yun. Thank you so much, Dr. Manalo. That's such very good news because, well, my mom's diabetic and I'm very scared if we get to the point of if we get there, dialysis. And yeah, thank you for that.
Yeah, Chris met this whole idea of whether to go into dialysis or not. Many patients feel that they have no option but to go into dialysis. But FYI, we have a program at the Medical City. We call it Conservative Kidney Management, CKM, Conservative Kidney Management, where we have nephrologists giving the option to patients that if they don't want dialysis because it's not consistent with their value system and their preferences for care, then the nephrologist can take care of them together with us, palliative care, the nutritionist, and we're going to come up with a plan of care so that they need not be forced into this whole idea that I have only dialysis as an option. We can manage their end-stage renal disease conservatively, medically. So kasi nga parang di ba, many patients fear dialysis and they did not be forced into going to something that is against their preferences for care. So check it out.
And I agree.
With the management.
Thank you, Dr. Manalo.
Okay, thank you very much, Kismet. And I just have a couple more questions, if that's okay. The number one question that I, of course, have, now that we have at least shared with you that today is also our launch day. Today is the day that after 6 months of hard work by the team, that we have decided to launch a little bit of what we have already. It's not the end product yet, it's just the start of the product. And Dr. Manalo, we wanted to ask if we could invite you to test it. We will give you an access to it. I'm sure that Kismet herself will want to reach out to you to test it, just because we are so proud of the little bit of effort that we're contributing to this space. We realize that palliative care is such a low number or a low state in the Philippines, and that's why we want to have these conversations. We want to be able to broadcast this. We want to popularize this. And towards that end, if because we will definitely reach out and ask you to test our product. But the other question was, is it possible for you to recommend the 80 other people for us to talk to? Because we want this webinar to be monthly and we want them to be able to share their work so that we can ask them questions, much like what we did here, where we're just sharing about the work that we're doing. And I think that if we are able to collaborate on that, like have these kinds of conversations on a monthly basis, then we can expect more people to be talking about palliative care and hospice care. So I'm just hoping, Dr. Manalo, that if I reach out to you to ask for Dr. Manalo, could you refer us to another palliative care specialist that we would love to share about their work? Is that okay?
Sure.
Mm.
In the hospital where I work, there are four of us specialists.
Mm-hmm.
That is such a luxury and a
Mm-hmm.
privilege because, as I said, you're lucky if you have one of us in that hospital. There are four of us.
Right.
So I'm sure any or all of them would want to speak about advanced care planning because it's what we do day in and day out in the hospital.
Mm-hmm.
And then we have the society, the Philippine
Right.
Society of Hospice and Palliative Medicine. We actually have a website
Okay.
that you can access, Philippine Society of Hospice and Palliative Medicine. I'm sure any member of the Philippine Society of the Hospice and Palliative Medicine would be more than happy to speak about advanced care planning. We actually had a postgraduate course, just an annual convention, just talking about advanced care planning about 2 or 3 years ago. Just a dedicated
Right.
postgraduate course and annual convention in advanced care planning. So
Right.
it's something that we want to promote nationwide,
All
actually.
right.
So if if through this webinar we can also widen our reach
Right.
so that more and more Filipinos and families would want to engage in advanced care planning, then we're helping each other also.
Well, that's wonderful to hear because correct me if I'm wrong, Dr. Manalo, are we talking about advanced care planning only happening almost now? Because when I was there in the Philippines, there was not even what advanced care planning. That was in 1980 or something,
Ah,
like years
yes,
ago.
yes, 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 yes.
Right.
No,
Right.
the specialization
The
of
specializations.
palliative medicine
Mhm.
only started in 2002.
There you go. Okay.
So earlier than 2002,
Right.
maybe some doctors were into it, but
Right.
not really, moving towards it collectively,
Right.
promoting it, doing it,
Right.
practicing it. Yeah, so 2002 is the cutoff, you might say.
Oh, of course.
Yeah.
So what's the growth projection for you for the Philippine Society of Hospice and Palliative Medicine or for just palliative care in general in the Philippines? What is that like in your horizon, your 10-year horizon?
Oh, the future is bright
Mm-hmm.
because the law is behind us.
Mm-hmm.
We have now the universal health care. We now have the National Integrated Cancer Control Program,
Okay.
both of which include palliative care in its provisions.
Mm-hmm.
And then we have, where I would like to give the credit to my colleague at the Medical City. She's one of the founder of the society, Dr. Agnes Bausa Claudio. She is really a pioneer and a visionary. We really salute her very much because many of the progress of palliative care and of the society and hospice Philippines in the Philippines is really something that she worked so hard for. Really overcoming hurdles, overcoming antagonisms from good people, you might say, um, because they have these misperceptions about us that we're taking patients away from other specialties,
Oh,
for example,
okay.
uh, because you're not going into ICU, so we're
Right.
taking patients away from critical care.
Sure.
Or we're doing pain management, so we're taking patients away from other services who manage pain. So, but as I said, Dr. Agnes Bausa Claudio has worked hand in hand with the Department of Health, and because now with the work of the Philippine Society of Hospice and Palliative Medicine and the other societies helping us, we now have the Manual of Operations and Procedures,
Okay.
Standard Operations and Procedures by the DOH.
Right.
We have the basic and intermediate training modules
Okay.
on palliative care for the National Hospice and Palliative Care Program of the Department of Health. And we actually have come up with the clinical practice guidelines. And again, hooray to Dr. Bausa for initiating that.
Right.
Clinical practice guidelines on palliative and end-of-life care
Mm-hmm.
for adult patients with cancer. With
Okay.
all those in place, PhilHealth now have the necessary data to
Mhm.
really propose that we come up with the support, financial
Right.
support to all our Filipino patients. So the
Right.
future is bright.
Mhm.
It's not yet, clear. As I said, we still have to overcome some hurdles from other societies. For example,
Right.
maybe, and we have the culture against us. Sadly, that's the way. It will always be the cultural barriers that are stopping our growth
Okay.
spurt, I'd say. So
Right.
so here is where education comes into the picture. We're educating young doctors, young nurses,
Mhm.
and we're trying to educate the public. That's why we conduct late fora,
Right.
and I do speak in other departments, hospitals, societies, talking
Right.
about what we do in palliative care. So we just have to keep on trying to make Filipinos understand life and death,
Right.
not with fear, but
Mhm.
accepting the reality, and having that peaceful and you might say Christian attitude to death and dying.
That is such a wonderful note. Thank you so much, Dr. Manalo. This was a highly successful webinar. This is our second, and we could not have invited a more better person. And also, it's just so nice to hear truths around what's actually happening. Because from our point of view, it's a lot of research, a lot of AI, a lot of reading research papers, a lot of studying. But to hear this come from you, this was such a blessing and a total gift. I thank you so much for your time. And I'm going to reach out next week because I'll be sending you a link to the webinar video where your video will be found, like I showed you in the community. And also, again, to reach out for the lead for the next speaker that we're going to have at the end of the month of May. So, uh,
Try reaching out to Dr. Claudio. She can tell you so much
okay,
about the history
right.
and yeah, everything that has been achieved so far as the promotion of palliative care and advanced care planning in the Philippines is concerned. She's really the expert on that.
Okay, and she is the one that's at Philippine Society of
Works with
Hospice.
me.
Oh,
Yeah, she
works with
works here
you.
at the Medical City.
Okay.
Yeah,
Okay,
and
I'll
she's the one doing all the work with the Department of Health at the same time.
okay. Well, thank you again, Dr. Manalo. And I will see you again hopefully soon because we will now that we have learned and gained so much from you. And remember, we have only been doing this for a couple of years of webinars. We're just so happy that this turned out to be the exactly the webinar that we need right now. As you have seen, we're a startup with a new app and we are just building it today. And hopefully in the next few months and maybe 2 years, it will grow as the conversation around advanced care planning grows. All right. Well, we'll see you next time and thank you again, Dr. Manalo.
Sure.
Okay. Bye-bye.
Bye.
Bye-bye. Ayan. Yan muna. Buti na lang nagstay kayo kasi I wanted to wrap up with the team and I will stop recording. Yan.